I'm Norman Swan. Welcome to this programme on suicide prevention. About 2,000 Australians take their own lives every year. For some, it's an impulsive, irrational act. For others, it's a considered choice. Many people take their own lives, harm themselves without warning. But usually there are signs, if only they are recognised. For health professionals, then, the question is how well prepared are we to both identify suicide risk and respond to it appropriately. Tonight we'll explore the role of primary healthcare professionals in suicide prevention. We'll look at examples of suicide prevention initiatives in Indigenous and non-Indigenous communities and discuss the uses and implementation of the National Strategic Framework, Living is for Everyone, a framework for prevention of suicide in Australia. Now, if you're watching this on your computer, you have the facility to type in your questions directly straight to us in the studio. You just click on the Live Talk tab on the web page you're looking at. And of course, it's a two-way street. It means we can ask questions of you. So here's one to get you going. Tell us where you're located in metropolitan, regional, rural, or remote Australia. Metropolitan, regional, rural, or remote Australia. And we'll come to the answers to those difficult questions later. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, and that is at rhef.com.au. But now let's meet our panel. Via teleconference from Griffith University in Queensland, we have joining us Professor Diego De Leo, who's Professor of Psychiatry and Director of the Australian Institute for Suicide Research and Prevention at Griffith University, where he also directs the World Health Organization's Collaborating Centre for Research and Training in Suicide Prevention. Welcome, Diego.
Welcome, and thanks. Good evening.
And by the way, that's a very out-of-date photograph of Diego. We can tell he looks nothing like that at the moment. And so if you bumped into him in the street, he's truly incognito tonight. And Diego's also a member of the Australian Suicide Prevention Advisory Committee. And his current research interests include suicide in the mentally well and suicide behaviour across different cultures. Tell me about suicide in the mentally well, Diego.
Well, we've been noticing since ever that a number of suicides occur in people who don't display signs of mental symptoms or mental disorders. And although this percentage of people have always been maintained to be very, very small, we have a sort of increasing perception that their number can be a bit bigger, and in particular we would like to understand on those smaller or bigger number of people what are the trajectories that bring them to commit suicide. So it's a very interesting line of research.
I mean, I thought that mental health professionals have been spending years telling us that it's a myth and really people are truly depressed and you don't need to look for those unusual reasons, that basically depression is the cause of suicide.
That is certainly correct in many cases, but sometimes depression is not full-blown. Sometimes depression is not really evident with traditional symptoms. Sometimes depression may take the form of equivalence, or sometimes depression may not be present in a clinical way in any particular form. And this is particularly the area which I was mentioning before.
Thanks, Diego. Let's go on with the introductions to the panel. Adele Cox is a Bunuba and Gidja woman from the Kimberley region of Western Australia. Welcome.
Thanks, Norman.
Adele is a member of the Australian Suicide Prevention Advisory Committee, the same committee that Diego is on. He's also an academic at the Centre for Aboriginal Medical and Dental Health at the Rural Clinical School at the University of WA. And until recently, Adele was chair of the National Indigenous Youth Movement of Australia. That's a nationwide youth movement? What's the story there?
Yes, that's a nationwide youth movement. It's a member organisation and is an organisation that was there to look after the young people who are 18 to 30 in terms of that age demographic, because often they were not picked up and looked after in most of the other usual youth programs that we know of.
And that's the high-risk demographic as well for suicide in Aboriginal communities.
Certainly the first half of that cohort is, yes.
We'll come back to some of the statistics in Indigenous communities in a moment. David Pearce is a general practitioner, been in practice in regional Victoria for 27 years, although his accent, as you're about to hear, will belie that. He has a specific interest in the treatment of depression and anxiety in general practice and in supporting clinicians to provide evidence-based care for depression and anxiety in routine practice. Welcome, David.
Thank you very much.
David's also an associate professor in the School of Rural Health at the University of Melbourne and is director of the Melbourne University Department of Rural Health. Tony G is a bereaved parent, as we'll hear in a moment, who lost his youngest daughter to suicide in 2005. Tony is a psychologist and currently works in private practice as well as on a sessional basis with Relationships Australia, Victorian Legal Aid and the Family and Federal Magistrates Court. He has a particular interest in men's issues and co-developed the Dad's Link programme for dads and kids in partnership with Relationships Australia and the YMCA. And in 2006, Tony helped establish the Life Is Foundation dedicated to suicide prevention, intervention and postvention. He currently develops and coordinates that foundation's programmes. Tony, tell me the story about your daughter.
Yes, it's there's very different. There can be a number of different versions of this story, but the one, I guess, my version is Nell was a very active. She's the youngest of three girls. She's a very active, determined, a loving child who basically sports loving. Who about 14 and a half, as a shock to me, took an overdose, and that started a whole kind of process, I suppose, until eventually taking her life in 2005.
What happened?
She was hospitalised for some time. I didn't think she was actually depressed. I'd be very interested in Diego's research around wellness and what factors in wellness. I think, actually, quite frankly, I don't really know what happened. I think there's, the why question that a lot of people really wrestle with. I think I'll probably have a different answer every day. I think there's a number of whys, and I suspect there were just so many issues that basically coalesced in her life, and so she eventually suicided. One of the interesting things, I guess, with Nell, and I'm a little detached from it because I like talking about this in a sense, because I think it's important to talk about these issues, and it's important to bring a personal face, I guess, to suicide. But one of the interesting things with Nell is that once we knew the risks and she was hospitalised and she was in the system, we still weren't able to save her. So I think that's another level of discussion, actually. I know tonight we're talking about identifying risks and so on. At the same time, I think there are a number of people we know they're at risks and we know they're greatly at risk. We don't seem to have all the services that may assist in saving them.
You are sounding detached about it. Were you able to talk to her? Did you ever get to anywhere near the bottom of what was going on in her mind? What did she say? Why did she take the overdose?
I don't think she actually knew fully. I think she knew there were a number of issues in her life. I actually think it's one of the, well, for some people, as probably we'll talk about, like suicide's such a complex, sort of multi-dimensional issue. I think, and some people may be clear about their wish to take their lives. I think for others, like Nellie, I think her choices became very, very clouded. So whether one would argue how rational she was in the final decision she made or not, I think that's a kind of debate. So I'm not sure whether she even knew in the end.
What sort of things did she say to you? You obviously asked her why. What did she say? Yeah,
she was unclear. Like she didn't, I think she felt let down. I know there were problems in her family. A separated family, which was one of the risk factors in most of the literature.
So she wasn't living with you at the time?
She was sharing. And her two older sisters were living with me, and I think in our particular situation, Nellie got a bit lost in family, you know, or lost in the dynamics. I think there were some issues at school. I think I actually thought her sport, she was a champion. She loved ice hockey, which is a very different sort of a sport for a child to take up, but I thought her sport would actually pull her through. But yeah, I think there are a whole range of issues which again, eventually sort of came to a point and she was not able to manage them. And again, I don't think the system was able to, you know, the mental health system was able to offer the sorts of help anyway that Nellie needed.
And the scar will run deep and forever.
Oh, definitely, you know, and you know, talking with others tonight, I mean, it's something that you don't actually get over. You know, as one of my daughters said, it's like, you know, life will never be kind of normal again, but you look at creating a new normal. And I think that can happen. You know, one of the reasons we've set up the foundation, one of the reasons I'm quite prepared to talk about Nell's death is to find, I guess, some meaning in it, but also to do what bits we can so that it doesn't happen to someone else, you know. And we'll talk more. I think it's very much a community issue, and I think all of us have a part to play in developing the sort of community that we want. Yeah.
Adele, you were sounding as if it was a familiar story to you.
Oh, very familiar. I think the whole the issue of being lost within family. You know, I think for a lot of Aboriginal and Torres Strait Islander young people, it's really about being lost between the two cultures, in terms of, you know, knowing who they are as a person, in terms of being proud of their identity, but also then having to, you know, the need to live in modern Australia. And for a lot of young kids, particularly those who come from rural areas, I think, who maybe move away from home for schooling, coming to the city is a whole other thing in terms of, you know, it's very foreign to them. So I think for a lot of young people, particularly a lot of young Aboriginal people, they're really trying to grapple with the whole living in two cultures thing.
Adele might correct me, but I was saying earlier that I think for Nellie in particular, she sort of lost her place in the world. She was unable to reconnect with whatever was her place in the world, and I know it's an Indigenous concept, that sense of place, and I think that's I find in a number of young people that I work with, that sense of just having lost their place in the world, which wherever that may be, between cultures, within family, within particular sides, there's just that sense of not finding place.
Familiar story for you, David?
Yes, and I mean, one of the things that goes through my mind as I hear the story, we listen to Tony's pain and courage and pain as he relates this, but perhaps we as GPs should remember that we will be in the professional end often involved in this situation, our careers, with our fellow GPs, ourselves, our other colleagues, and how we need to do some constructive with our peers so that the distress that they feel through being perhaps the sense of failure can be dealt with in a constructive sort of way.
Diego, listening to this story, you start to wonder about the challenge of prevention and detection and how dinkum, in a sense, the information that's been given to general practitioners and others about suicide and suicide prevention, if there is this layer of complexity, it makes it pretty tough to detect and prevent.
It is, but it is very probable that we are actually preventing deaths even not knowing it clearly, because it's very rare that patients come back to you and say, well, you know, doc, that day you saved my life because I was going to hang myself or doing something else. But certainly this happens, and sometimes suicide are just avoided by an unpredictable event or an unpredictable intercurring person or feeling, emotion.
So where does, if we're talking about teenagers and adolescents, where does impulsivity sit in this story?
Well, I don't know because the particulars were not enough.
Sorry, I'm not necessarily talking about now, but in general.
Well, in general, in adolescence is clearly very, very high, the danger of impulsive behaviors, dramatic reactions. That's why, for example, it's so important to control the media because when they talk about suicide, they are read or seen also by very vulnerable individuals in which adolescence represents a very difficult and transient period of life with black and white reaction, very burning feelings of reaction. So if the impulsiveness is probably in 50% of suicidal behaviors, particularly in fatal behaviors, in adolescence, this impulsiveness is estimated to reach 70 or 80% of cases.
I think particularly when it's linked with alcohol or substance abuse, there's impulsivity, and it's a sort of a toxic mix. And
so, what are the risk factors, David? What creates the vulnerability? What are things that you look for?
Experience of mental illness, in particular depression. Sometimes early psychosis can be associated with suicidal actions. Isolation, and we might talk later about the isolation in all of its senses, but isolation isn't just geographical isolation, it could be emotional isolation or isolation from support. Certainly drug and alcohol issues are really very important. The age group we're talking about is a little bit different, but we know that there are certain key ages, particularly in males, that are much more at risk. Males with multiple problems and who don't have supports are a key group that we'd be concerned about.
And separated males in particular.
Separate males in particular, yes.
Relationship breakdown, and yes.
And binge drinking with the rebound, and also amphetamines and ice and so on with the rebound involved there.
Yeah.
And what about in Aboriginal communities? Are they different or the same vulnerabilities?
Look, most of them are the same, but I think there are the added complexities of adding in some of the other cultural factors. Particularly, I think, as we've spoken about briefly, that connection to country, connection to kin, and knowing one's place. But I think wanted to pick up on the isolation thing, and there's also another level of isolation that we see for Aboriginal people, particularly who are living in urban settings. And I know the focus is on rural, but it's a psychological and psychosocial isolation. Particularly when services...
I think Diego calls it emotional isolation. Or are you talking about something different?
Well, there's the emotional isolation, but there's also this other psychosocial, sort of psychological isolation, particularly when it relates to services not being culturally appropriate. And the sense that people feel isolated, even though they might be in a town where a particular service is available, the fact that they still don't feel comfortable in accessing service.
They've got nowhere to go.
There's another level of isolation.
So there's a sense of entrapment. Diego, when one talks about psychological distress, is this just something obvious? You know it when you see it, or can it be assessed?
Well, it depends, because clearly there are persons of all sorts, and there are person able to dissimulate it or to control it to a degree until it reaches that fatal threshold. There are other persons, probably the majority, in which mental distress can be much more visible and can take particularly the shape of anxiety-like symptoms in which people can obviously not looking at rest or at peace, and these may be accompanied by the visualization of concern, of capacity to find solution. The idea of entrapment that has been already expressed is clearly one of the concepts that most recently have been isolated to identify a suicidal syndrome, and this symptom should find an answer sometimes quickly in order to avoid developing into something more serious, but not always
Tony?
is the case.
Yeah. I would also add the dimension of hopelessness, which I think probably if someone's in a consultation, it's often a severe sense of loss, but also a severe sense of hopelessness that certainly people I see, that alerts me to a higher level of risk.
Let's get the answers to the first poll question that we put out to those of you watching on computer. Where are you located in Australia? Metropolitan, regional, rural and remote. So rural is the blue, and 40% of you are coming, or define yourself as rural, 10% as remote and 20% as regional, and 30% are watching from the cities. So welcome to our city watcher viewers who are, as I said before, finding out where truly good education is occurring for general practitioners, and we welcome you to the fold. Diego, there's been a controversy. A lot of people are going to be watching this program as a recorded program, but this week that we're recording this program, there's been controversy about suicide figures, claiming that suicide prevention programs have actually not been working, despite some figures suggesting there's been a decline. What is the story with suicide figures in Australia?
Well, unfortunately, the official statistics are not, in my view, reflective of the real situation, and these can be testified by my institute work in Queensland, where we manage the Queensland Suicide Register, so we have the real cases here. We don't have abstract figures. We have each individual dossier. And in Queensland, the underreporting has been of the order of 40%.
Sorry, 40%?
40.
It's huge.
Huge. We have indirect evidence that a similar figure can be from New South Wales, whilst we have, and New South Wales and Queensland makes approximately half of the Australian population, while from the rest of the country, apparently the reporting has been of better quality. Having said that, probably the numbers of suicide have not been declining, and probably not even rates, the relative numbers have been declining. But this doesn't mean necessarily that the suicide prevention strategy hasn't worked, because
you don't know what it might have been.
Yeah, exactly, and because the population has been changing in composition and in numbers very remarkably, so with very good and positive aspects, but also probably with some new aspect of seclusion, of difficulty, of segregation that needs to be taken into account.
So, Adele, what about Indigenous communities?
In terms of
suicide rates?
The rates, look, they're still high in our communities, and I think a lot of the data, whether you're looking at 1997 or even now, the rate specifically for Indigenous suicides, particularly amongst males, is still 40% higher than the rest of the population.
And higher in rural, even allowing for Indigenous communities?
Yes, it's higher in rural areas and becomes, some of the figures suggest, higher the more remote the location. Just reflecting on this
broader. Is that isolation issue, or just the violent means are nearer to hand?
Or maybe all of the above, including limited access. So there's much less support available at times of distress, with health professionals and community support. So perhaps putting all of those together, we can begin to understand why it might occur more significantly in rural areas.
So Fred Strawn, a medical student, has sent in a question of talking about the higher rates of suicide in rural areas, wondering how that matches with the sort of image of, this is where you go to relax, relieve stress, the bucolic nature of rural life, escaping the big nasty city. He's suggesting there's a paradox here.
Well, there is. Rural life is marvellous and difficult all at the same time.
So we're allowed paradoxes?
We're allowed paradoxes.
But it's the same in Indigenous communities.
Yes.
You have self-supporting communities
I was
and
gonna
yet
say,
people get isolated.
rural and remote life, if you're visiting, is brilliant.
It's a nice place to visit. Yes.
When you're living there on a full-time basis, it's a different story. You see and you view the place a lot differently.
And do young kids find, if you talk to, say, a Greek or an Italian kid, they'll often say they feel smothered, although in those sort of migrant communities, I understand the rates are actually less than in other communities. But do kids report feeling a bit smothered by the inclusiveness of an Aboriginal community? There's that paradox as well?
Yeah, look, as you get older, it's one of those things where, you, as a kid, I think you take for granted a lot of things. And you don't realise it at the time, but I think being smothered and having family and support around you is actually, particularly in terms of mental health and where kids are at higher risk. There are some other social, population studies that have been done that show the kids were less likely to be at high risk for having mental health problems generally out in remote areas.
Supportive communities, supportive schools.
Yes.
There's a lot of evidence for that.
Throwing just briefly, I was recently lucky enough to go to some remote areas in China or Tibet, as it was known, and I talked to whoever I could talk to about an experience of suicide in these communities, and they didn't understand. It didn't happen, and what we found there was that there was almost 3 layers of protection. There was very close family groups, especially in the remote areas. There was also another layer of the social fabric in the community, a very close community, and also there was very strong religious beliefs.
And John West from Chevron Island asks, are all Lifeline phone counsellors capable of handling suicide intervention and deciding the suicidality of the caller? Diego, do you know the answer to that question?
I didn't get it precisely. The question concerns...
The question is, what are Lifeline counsellors all trained in dealing with suicide, of detecting suicidality and dealing with it?
Yes. Well, they should.
Right.
There are designated suicide helplines, and those telephone counsellors have specific training in dealing with suicidal callers.
Okay. Corey Cupid, a psychologist in South Australia, asks, what approach do you recommend for managing self-harming teenagers? David?
This is a complicated...
Because self-harm is a high risk.
Self-harm is a high risk, and it's an indicator that this young person needs understanding, support, and recognition of why the self-harm is occurring. Sometimes the self-harm can just be managed at, let's fix up the cuts and off they go, rather than exploring what's happening in that person's life and trying to then develop strategies to help them address the issues in their life that are putting them at risk of subsequent suicide.
I'm going to ask you another question now. How confident are you in raising the question of suicide with your patients or clients who might be at risk? Are you very confident? Are you confident? A little hesitant, or you wouldn't do it? If you could answer that question as honestly as possible. Those are for our computer-based viewers. That would be great. We'll come back to the answers in a minute. Marissa Pillar from North Queensland asks, we talk about the issues in teenagers. Should we be looking at younger children where perhaps the seed is being laid? Any comments?
Apart from I agree. Look, having had direct family experience of a 9-year-old cousin, die by suicide is hard enough to deal with. But as a mother of a young child, I think, well, where and how do our children even get suicidal ideation at that age is just beyond me.
I'd agree how important and sort of crucible the family is, or a container the family is, for all sorts of constructive or destructive behaviours. So, yeah.
Although it's worth remembering in young rural males, 15 to 25 is a peak age group, and that's often a time of transition from family to some other setting, and to re-establishment of useful support structures are very particularly important.
Yes. Rosemary Duggan from Victoria has come in with an answer to our question. This is why I love webcasts. We get more answers from our web audience than we do from our panel sometimes, with all due respect to our panel. Rosemary Duggan from Victoria tells us all Lifeline counsellors now attend a 2-day applied suicide intervention support technique training course as part of their training. Thank you very much, Rosemary Duggan. Feel free to interject along those lines. A nurse from the ACT asks, ED triage systems flag children's frequent flyers and raise alerts. There's no automatic equivalent system for mental health frequent flyers who want to self-harm. Diego, do you want to comment on that?
On the issue of self-harming
and flags, whether or not there was a study, I think, in Western Australia from memory, done from the Institute of Child Health Research, which found that EDs were not good at identifying high-risk people coming through with self-harm. In other words, flagging them the way you might flag somebody with coronary heart disease or some other problem.
Well, I believe that this is one of the areas in which we are probably progressing more rapidly now in terms of treating suicidal behavior, because there is a changing sensitivity towards this, and particularly in youth, especially thanks to a couple of large American studies and to an European study called CASE study, which child and adolescent suicide and self-harm in Europe. And this study, which were run in large hospitals only on kids in America and in schools through deep questionnaires in Europe, have raised substantial attention on how first youth present to emergency departments, and B, on the way in which they should be investigated, which is a bit different than the way in which an adult should be investigated, clearly. And it is essential, since some species of self-harming, like cutting, are skyrocketing in terms of prevalence. Clearly, we don't have to be judgmental, and sometimes, as it's evidenced lately, we don't have even to pretend that we are understanding, because we may not be understanding their reasons. And this is also one of the usual obstacles in being approached by youth. As you know, young people, particularly adolescents, don't enter so easily in contact with their GPs.
So it becomes the ticket of entry, and you've got to basically respond to some extent in a formulaic way to make sure that you ask the right questions. We'll come to this in a moment with a role play. We're certainly getting in comments on the Lifeline counsellor issue. Stephanie from South Australia says, I'm a Lifeline counsellor. We're well trained in suicide intervention and recognise the risks or level of suicidality, and we have supervisors who we must contact if we have any concerns about suicide. We'll come back to, well, another question actually interestingly, just before we get onto the story. How at risk, this is a question from Sydney, how at risk are siblings of suicide attemptees or successful people who've successfully completed, are there familial risk factors? Diego?
Well, yes, there are, in the sense that there is clearly the imitation of a problem-solving strategy. There is the strong identification, and there may be some genetic loading for psychiatric diseases that may be mediator with suicidal behavior, but there are also very convincing genetic factors which are embedded with the discontrol, and which means with the capacity from an individual of controlling powerful feelings.
David, what about your position?
Well, clearly as general practitioners, we see the obvious distress with another members of the family, and the closer the person is to the one who suicided, the greater the likelihood of that distress to manifest itself as depressive illness, which of course is a common precursor for a suicide.
Let's take a look at one of the ways you can formulate questions that may need to be asked. This is role play with general practitioner Jane Gunn with a 17-year-old patient, Chris, who presents, well, you'll see how he presents for yourself.
So Chris, how can I help you today?
We probably can't really. I just haven't really been sleeping for a while. Thought I should come in, but there's not much point really.
You said you haven't been sleeping well. Do you want to tell me a little bit about that?
I'll just be lying in bed and just thinking about things, and I just can't sleep, and I'll get all hot and sweaty, and I just maybe get up and play guitar or something and go on the internet maybe.
So how long has this been going on for you?
I don't know, quite a while, a couple of
Has it?
weeks, a while, yeah.
Have you told anybody else about it? It seems like it's really worrying you at the moment.
It gets me down a bit, just thinking about everything, and yeah, end up feeling pretty bad by the end of the night.
What sort of things are you thinking about?
Just like just this whole town, like how just everything's just gone to shit for me. Like nothing's ever going to change. You know, like there's no point to anything anymore. You know.
You feel there's no point to anything?
No.
That's a pretty horrible way to be feeling. How long have you been feeling like this?
I don't know, ages.
Is it months and months or weeks? What sort of time frame?
Months and months. Yeah.
Well, look, I'm really glad that you came in today because I think it's good to talk about these things. Can you just tell me a little bit about what you're doing at the moment?
Nothing really. I haven't been at school for a couple of weeks. I missed out on quite a bit. My parents have gone away for the weekend, and I don't know what I've been doing. Just same thing every day. Really, I don't play footy or anything like the other guys. I don't go out that much. I sort of stay at home, really.
What year are you in again?
Year 12.
Year 12. Gosh,
Yeah.
I mean that's a huge year as well. How's it going?
Not great.
No. So it sounds like you don't feel like you're really fitting in,
No, I've never fitted in.
haven't you?
No.
That must make you feel a bit bad as well, does it?
Yeah.
Have you got anyone to talk to about these sorts of things?
No.
So you've just been really bottling it up just inside yourself?
Yeah.
Yes. Obviously this is a really difficult thing for you to talk about, and you're not feeling really great at the moment, are you?
No.
No. So when you haven't been sleeping for a couple of weeks and you're really feeling left out and like you don't belong in things, how bad has that feeling got?
Pretty terrible. I just don't see the point of anything anymore. Like, you know, it's like there's just nothing.
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 Have you had any thoughts of, harming yourself or hurting yourself in any way?
So I've thought about it.
Have you? What have you thought about?
You know, I don't know, just I've been down to the garage downstairs. Dad does a bit of boating and fishing and stuff, and he's got some, I don't know, rope down there.
Has he? And have you thought about using that rope?
Yeah.
Gee, things have obviously been really, really difficult for you. Do you feel that there's a risk that you might actually use the rope to hurt yourself?
When I go home tonight, I might.
You might. So you're really feeling very, very bad today. Yeah. Look, it's really good that you've come to talk about it, okay? It's a very hard thing to talk about. But one of the really important things with talking about it is that you can share that worry, and that, I can actually help you so that things don't have to be as bad as they are at the moment for you.
Okay.
Would you like to help with how you're feeling at the moment?
Yeah.
You would?
Yeah.
Well, I think that we're going to have a really good look at how things are going for you today, and just work out a plan so that we get you through the next little while and start to work on things to make it better. How does that sound?
Thanks to Grant Blaschke from the Nossal Institute for Global Health at the University of Melbourne for use of that resource, which is made for Beyond Blue and funded through the Suicide in Men programme. Before we go to discussion on that video, let's talk about your results. How confident are you in raising the question of suicide with people that you're coming in contact with at risk? And a pretty positive result there. Most of you are confident, and a significant proportion are very confident. Nobody wouldn't do it, and some of you are a little hesitant. But the vast majority sound confident enough to actually do it. So well done. That's a good response. There. What on earth is this general practitioner going to do about this? I mean, I assume that this is a rare occasion that something like this happens.
Rare, but we all remember it. It's such a difficult circumstance. What's the GP going to do? Well, we know a great deal now about Chris. We know it's been established that he is severely depressed. How bad is this problem? It is really bad, he says, and he's got suicidal thoughts. He's in fact got suicidal plan. He's at high risk. He needs intervention to provide support for him today. That may include, in fact, in these circumstances involving the support of other health professionals, an emergency team from psychiatric team.
Which doesn't always exist.
That
in
may
a
not
country
be.
town.
That may not be available. It may be a case of ensuring that he understands that there is some light at the end of the tunnel. His tunnel is very black and dark. That there are strategies and helps that will, in fact, give him some hope and some light. And that may involve, with his permission, involving a family support member, a best friend, a buddy who will keep close contact with him over the next day or two. It will mean very early review. It's likely we'd want to see him again in a day or two to ensure what's happening. And it may be a circumstance where medication might be considered.
But it's not going to work overnight.
Correct, and that's why the supports are necessary for his safety and well-being. It may be, in fact, formally involved in the mental health sector, but if that's not available, as you say, it may well be developed a local network.
And so,
for him.
if you're in a small country town, a few hundred people, and he says everybody's away this weekend, as he implied, there's nobody around, I don't have any friends anymore, they can't be bothered with me. What are you going to do next?
Great difficulty, right? With great difficulty.
Because somebody's got to be by his side.
Somebody needs to be with
time.
him. That's right, and that person isn't available. It's often we can find. It's interesting when we talk to young people and to young adults. The people that are most influential and important to them are their family and their mates. And so it may be a situation if family is not available, trying to identify which of his mates are important. But you're right, sometimes he will feel alienated from his friends, even though he may not be. This perception from his severe depression may well be one of alienation. So maybe encouraging him to see that, in fact, there is support there that can be a benefit to him.
What if he was an Aboriginal boy? Again, he wouldn't be coming forward, would he?
He certainly, most likely wouldn't be. Not that he certainly wouldn't. I hope that we as a society can get to a stage where our young people feel confident that they can actually come in and discuss issues such as that. But in the reality of the face of despair, a lot of the young Aboriginal kids who are living out in rural and remote areas, often it is the families and the mates who are the ones that we need to be looking at supporting at the same time, as well as recognising the important role that general practitioners and any allied health provider has in a lot of these settings. Reality, we know, is that they're not going to come forward. And how do we better support and manage that? And of course, the other reality is an issue such as that going to be raised between 9 and 5.
So we actually have a question here relevant to this. How should GPs react when, if, for example, it was a non-family member reporting this boy, Chris, who they reckon was at suicide risk? What do you do? And
that's in fact not at all uncommon. We're concern expressed by a family member, and most commonly the family member says, but you mustn't tell them that I rang, which makes our life even more difficult. I think we have to act carefully, but with the best interests of our patient in mind, and try to seek to make contact with the other person. Often they may be encouraged to come in for a checkup or for follow-up, and if we are aware of their risk setting, we have the chance to ask some questions to try to really understand where they're at in life.
Tony, have you got a comment here?
I was just reflecting actually on something that Adele was saying, and then David added to it. But it's almost how, I mean, it's a broad thing, but how one can include community again, or you know, especially in remote areas, and how one can energise community as support for someone like at risk.
Diego,
Yeah.
what's the role of hospital admission here? Diego, are you there?
Yes, sure. Sorry?
What's the role of hospital admission in this story of Chris?
Well, it could be hospitalized because this is the remedy that many times we take when the situation is unmanageable otherwise, or when there is no support, no friends, no family members, no partners able to monitor the person. Clearly, sometimes it's a situation that carries many side effects because the mental disorder may not be entirely there, so is a custody more than anything else, and as such, the psychiatric environment is not ideal. But we don't have intermediate structures or similar avenues. But I wanted to express a recommendation, if it's possible, based on this case. This case clearly presented a guy with a plan, and this plan was declared to the doctor. And sometimes we are appreciating a risk as high if the patient tells us that there is a plan. But we may remember, or we must remember actually, that people who are seriously determined to die often are not going to tell us that they have a plan. And so we don't have to lessen our vigilance in those not reporting a plan.
So the standard questions that we're using can give one a false sense of security, is what you're saying.
Exactly.
So does that suggest that the risk assessment tools are not entirely reliable?
Clearly not.
That's a sobering thought, Professor DeLeo.
That's what I think, unfortunately.
Let me ask another question of the audience. Have you undertaken any suicide intervention or prevention training? Yes or no? It would be interesting to hear the answer to that question. We've got some very pointed remarks or questions on the from our web audience and our live audience as well. Our video, our broadcast audience, I should say. From Kim Delati, New South Wales, rural areas pose one of the highest risks for completed suicides due to isolation, the lack of mental health services available in remote areas, and limited government funding. What's the panel solution in dealing with the barriers to suicide prevention in rural areas? Adele? If you had that, you wouldn't be here.
Yeah, look, it's an issue, and I think there's in terms of knowing what some of these solutions are, there's a gap in terms of our own knowledge of what some of the good programs are that are working. I think, I live in Perth, but I'm, excuse me, I'm from the Kimberley, and I see that there are, and certainly from work that I myself did when I was still living in the Kimberley with youth suicide, there's more opportunities in rural settings to actually do things and get hold of communities mobilised, I think, as Tony was pointing to.
You can get a hold of things.
It's a lot harder in urban settings, yes. And that's coming from experience.
And of course, the other thing that we're not talking about here, and I must just reverse back to the Chris story, is we haven't talked about comorbidities. We haven't talked about other mental illnesses, and we haven't talked about drug and alcohol. And that could clearly be an issue which is not being raised, and also not something that's terribly easy to deal with in the acute situation where you're having to deal with the boy. This is a longer term issue.
Yes.
Which again suggests how complex the situations are. Yeah.
Question from Rosalind Nelson to you, Adele. Rosalind Nelson's from North Queensland. Having short and long-term goals can be somewhat of a protective factor. is this more difficult for remote Indigenous youth, having these goals?
No, but I think what we've tended to do, both historically and even now, is I don't think our kids are, it's not promoted to a lot of Aboriginal kids that goal setting is something that they can do.
And translated, we've talked about social support a moment ago as being important to protective factor, but also setting goals and having expectations of you are important too.
Yeah, because you imagine a setting where a child walks into a classroom, and if that young child is quickly dismissed as not assuming that he or she has any goals, that child then starts to live out that particular issue.
Let's go to the next case study. Derek's 66 years old. He's a Vietnam veteran living in rural Victoria. He's on a TPI pension for post-traumatic stress disorder and has been taking antidepressants. And they recently lost their house in the bushfires. He comes to see you, David, complaining he's having trouble sleeping, generally feeling pretty worn out. Suicide risk?
Significant suicide risk.
Why? There'll be lots of people in the bushfires feeling a bit worn out.
And it's a significant risk. Fortunately, the majority of patients who are at risk don't complete a suicide, but we want to try and identify and support those who are at risk. This guy's in significant distress. He's had a long history of stressors from his PTSD. He's now had a very major stressor added on top of that. What's really perhaps important...
So you're adding up the stresses that he's under.
Yeah, stressors, and I want to know what he's feeling. He's saying, I'm feeling worn out. What really does he mean? Is he in fact expressing depression? So we need to find out, is this guy depressed or not? I suspect it's highly likely that he is. And as the next stage, we want to find out what is specific suicide risk, some of the factors we talked about.
So he's a silent type, particularly, he's mistrustful, PTSD has made him so, he's prone to violent outbursts, and he just is climbing up. He's not telling you anything.
It will take time, and the advantage of being a GP is it's highly likely this guy will know us as his GP and we will know him. So we have established credibility and got the chance to perhaps let him tell us just where he's at. We understand it's very difficult. Tell us about it now. The more difficult situation is sometimes if you see this and they're the patient of a colleague and you don't know them well at all, or they happen to be a visitor. That's an even increased layer of complexity. But for this guy, we want to really understand where he's at so we can try to develop a plan with him. Hopefully he's got a partner that may be of assistance.
If Diego's right, and no reason to expect he's not, you've got to suspect this in almost everybody. Your index of suspicion has got to be pretty high if the standard questioning doesn't necessarily give you the clue.
I think suspicion needs to be fairly high, but we also have to work in a practical clinical setting.
Well, and I think also, like, experienced practitioners have an intuition about such things, and I think intuition is
intuition can be wrong too.
Well, it can be wrong, but there's
so intuition that is okay.
But I think it's useful as part of an assessment tool, as part of the assessment tools. The other thing I'd want to know from Derek is his absence of hope. I mean, it's a simple thing, but that hopelessness scale is often critical in suicidality.
Diego, with all the bad press that antidepressants have been getting, and the fear that some GPs may have that the agitation that may result from putting somebody on SSRI might actually throw him over the edge, just what's the story there? How accurate is that view?
I think that there is also a very recent publication from a Canadian group that has discovered a couple of genes which are implicated potentially in severe anxiety at the beginning of a treatment with antidepressants. Look, this issue has been running for decades and has imposed in different nations different attitudes in protocols. For example, in many European countries, still you don't start an antidepressant treatment without sedating drugs. And this because of the danger of having excitatory reaction at the beginning and particularly the an inhibition of those slowing down that depression created, so you can act on your suicidal behavior while before you were inhibited. I believe that the state of the art today is that we have green light for antidepressant on the elderly. We have to be careful with antidepressants in general in adults, and we have to be extremely careful with antidepressants in adolescents.
And so the message here is that it's going to take a while to work anyway, so you've got to have support in earlier and deal with this and try and prevent the situation. Yes. Susan Smith of WA asks, what are some of the options for people who refuse to access crisis services? What do you think, Adele? I suppose you could go for an involuntary treatment order.
That's true.
You could, and I can certainly think of a number of occasions where I've seen that play out. Look, I can't stress enough how important the families and communities are in terms of helping.
Yeah. Let's get the result of poll question 3, which asks you whether or not you had any training in prevention or intervention, yes or no. What have been the answers there? And the answer is 57% yes, 42% no. So half and half roughly. So a way to go yet in terms of training. Let's go to very quickly in the last couple of minutes to our last case study. Charlie's 24 years old from a remote Aboriginal community. Remote meaning 250k from the nearest town. He's been working for the last 6 months and drinking excessively, and he's actually had suicide attempts in the past. And the mother's recently spoken with the local GP about her concerns for her son and his most recent attempt. Adele, I thought being in work was a protective factor.
It normally is, but I think in that particular case, the fact that he's tried before certainly puts him at higher risk or at risk of trying it again, I guess.
But the fact that he's had more than one suggests the system's failed him.
It has, and I think for us as practitioners, or for you guys as practitioners, it's really about how do you manage and how do you get into, delve into finding out what some of these other underlying causes are.
What can you do for someone like Charlie? Because he's been brought in by his mother. He's not necessarily a willing participant in this.
He may not see that it's an issue, but I think, he will do, the fact that he's tried a couple of times. I mean, for me, the initial concern, I think, should be to Mum, who's obviously raised this, in terms of checking and, well, how is she coping? She's obviously going to be the one that's going back to the community.
And incredibly frustrated because there is a good chance he could complete.
Yes, and could do something in the time that, she's away or the next time she's gone. Look, the fact that he's not working, I think, brings back to Diego's original point, that often the signs sometimes just aren't there. And I think that's what makes it so much more complex.
This is just much more complicated than we think. Tell me about this strategic framework, Diego, the LIFE framework.
Well, it is a combination of general population and high-risk group strategies. It is a very good document, is very comprehensive and has been carefully meditated. So in theory, the strategy is excellent. Now, the problem is how to implement it and how to control its implementation, because this is something that is everybody's business. And so we need all to cooperate and aggregate around the themes of the LIFE framework.
What's the role of the GP here, David, in this framework?
Setting?
In the LIFE framework?
Yeah, I mean, I think a key issue for the GPs is that we need to see that our role as influential members, particularly in rural communities, isn't just in our consulting room. We have a key role in influencing and encouraging prevention and support programs in the community. I think we can have a really very significant influence in that regard.
And what about families after suicide? Does the framework have a role there?
Yes, the term is known as like postvention, and yes, the framework covers postvention services and supports. You mentioned before about families and siblings having elevated risk if they've lost someone. So this also can be a remarkable resilience, and there's support groups set up specifically for survivors, as they're called, of suicide. Compassionate Friends runs them. They're right throughout the country.
There's a question here, this has been sitting here for a while, from Kim Delati, another one from Kim Delati, New South Wales, asking about post-vention in offender populations, given that self-harm and suicide attempts are quite high in offender populations.
No, okay, yes. I don't know about specific post-vention programs in, maybe one of the listeners might, one of the viewers might know that, yes, yeah.
So what are your take-home messages?
For me?
Mm-hmm.
I think, as I've said a number of times, I really do think it's around community, developing supportive communities. I think it's also about, we tend to focus on risk and so on. I really like broader programs as well that focus on wellness and building strengths and capacities. And I think my last one is that, while we can talk about like abstract populations, suicide affects individuals, kind of thing. And can affect individuals in different ways. Yep.
I just noticed here a question from Tasmania. Where can I access suicide prevention training in Tasmania? We're not necessarily going to be able to answer that question, but we'll try very hard to put it up on the Rural Health Education Foundation's website. So thank you for that, our viewer from Tasmania. Diego, what are your take-home messages?
That we need to care, not just to make the appropriate therapy. Meaning by that even if we had state-of-the-art protocols, they may not be enough to save a life. And we have to be aware that, particularly from the perspective of a suicidal person, we need to be believed as carers. And so they have to be convinced that we are really caring for them.
So what you're saying there is make a connection, and that connection could be life-saving.
Yeah.
David?
Well, I think as GPs, we have a central role in terms of effectively managing the issue of suicide in the community. I think clearly our awareness needs to be raised, our skills and identification and response need to be developed and honed, as in lots of other clinical areas. And that response can be perhaps needs to be customised to the particular setting we work in, particularly in rural Australia, so it's effective within our own community. And that as GPs, as influential and hopefully respected members of our community, we can have an active role outside our consulting room in terms of particularly life wellness and prevention strategies.
Adele?
Which is probably a nice tie into mine, and my take-home message really is that suicide is everybody's business. And we've had some brilliant results of programs that have worked in rural settings because they literally have made the local bartender and the local school gardener aware of what the issues were. And we've seen huge turnarounds because of that.
Thank you very much to you all. Thank you, Diego, for coming online from Brisbane. He's been pluckily sitting there on the end of a phone, so thank you very much, Diego. And I hope you've got a lot from tonight's program on suicide prevention. I certainly have. Thank you to all our viewers and webcasters. There's a Living Works website, apparently, for the Assist course. That might help our person from Tasmania. But again, we'll put that on our website because we'll put more information about the issues raised in this program and a number of resources on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms. That's how we improve our programs for you. Please register for CPD points by completing the attendance sheet. I'm Norman Swan. I'll see you next time. Good night.